challenges, and then talk just a little bit about the end about the challenges that Maryland hospitals face uniquely in the country around how we earn our revenue, and what is special about MedStar St. Mary's that they really didn't anticipate when they put this new program into effect about 2 years ago, just starting our third year. So let's see if I... Studio, we just next it here? Okay, so I'm going to flip these around. So the vision of MedStar Health, of which the former St. Mary's Hospital is now a proud member of, is to be the trusted leader in caring for people and advancing health. And so this encompasses the entire system, but each individual entity, and in fact this hospital has had the same mission for quite some time, and that's to be a community hospital that upholds its tradition of caring by continuously promoting, maintaining, and improving health through education and services while assuring high quality patient safety and physical integrity. So we get up every morning, and this is what our goal is to do, and we guide ourselves and our associates through the use of our SPIRIT values. So SPIRIT stands for service, patient first, integrity, respect, innovation, and teamwork. Now, when I talk about this, every time I do a new associate orientation, I let people know that this, to me, means that we're delivering care like we would like care delivered to us, or as if we were delivering care to a family member. And in fact, as you probably know, over 85% of the associates who work at the hospital live in St. Mary's County. And I think that that's what gives MedStar St. Mary's that special touch and feel. And, you know, this is people come to work day to day, and it's a job, and it becomes a routine. And I keep trying to help people keep in mind that it's not routine for our patients, and we've got to make it a special event every time they come. So I'm going to talk a little bit about things that you all know about, but St. Mary's County, and I think everyone saw in the paper, the Enterprise, a couple of months ago that we had crested over 111,000 people. So that's quite a significant growth. We are a fairly affluent community with a median income of $85,000, a little over, and but 7.7 of us live in poverty, and that's those are issues that we try to reach out and deal with every day here at the hospital. We're a fairly young community, but again, the recent statistics show that the county is aging faster than the state average, and so there is a shift, and we've noticed a shift in the number of Medicare patients that we're taking care of here at the hospital. We, and you'll see in just a second, we've chronically suffered with the ability to recruit physicians and healthcare providers down in St. Mary's County. And that's part of the reason that St. Mary's Hospital made the strategic move to join the MedStar system. And over the course of the 6 or 7 years that we've now been part of the system, we've been able to execute quite significantly on the goal of recruiting additional physicians, changing the culture of transferring everything to Washington or Baltimore, but and allowing residents of St. Mary's County to get the type of high quality, high tech community care that we should be able to provide. And I'm really thrilled to say that I think we're executing on that strategy. You can see some other demographics of the county, and then some of the unique populations that we serve. So here are some vital statistics. They're broken down. I'm not sure if everyone can see these, but these numbers seem to be going down when in fact you've got to add the first two columns to really get a flare of what type of growth the hospital is seeing. Probably a better way to talk about the growth is to say that in 2014, this hospital was licensed for 81 beds. And the way the license number is calculated, it's 140% of your average daily census. So even though we have 125 beds possible in the hospital, the state looks at our average daily census and puts our number at 140% of that of our average daily census. In 2015, our licensed number of beds went from 81 to 92. So 92 beds, that's 11% increase in 1 year. In 2016, it's just been released that our licensed number of beds is now 103. And so what you can see is year-over-year growth of over 10%. And I can tell you that in the last 12 months we've had sustained very, very high census with numbers approaching 120, 122 on not infrequent basis and consistently above 105 patients. So really, the volumes at the hospital have grown, and this is because, I think, of what I spoke about a few minutes earlier, a goal to strategically increase the services available at the hospital. And you can see here that in FY15, all these asterisks are areas where we've had record volumes over the last year. So the hospital is now 104 years old. I'm sure many in the room are old enough to remember the 1984 hospital, and the last renovation was done in 2008. Because of the growth in the hospital that I just spoke about, we are in the process of doing a strategic facility plan, because at some point, if the growth we've experienced continues, we'll be at our maximum capacity. So we're blessed with a large 55-acre campus, and we are going to be looking to see where the next bed, what the next facility looks like. And it's not just a standard, hospital anymore. We have to really think about what hospitals of the future are going to look like, what kind of operating rooms we need. So it's a really interesting and innovative project that we're under, and we'll be updating the community as we get more information. These types of projects take years to implement. So we're not talking about a shovel in the ground in 1 year, 2 year, 5 years. It could be 10 years away, but that's how long these projects take to get going. So as I spoke about earlier, MedStar St. Mary's joined, St. Mary's Hospital joined the MedStar Health System back in 2009. I spoke about the reasons, and the primary reason was to improve physician recruitment and retention. When we talk about stronger financial backing, it's not that the hospital was in any financial difficulty. It was really an issue of the board and the leadership under Chris Ray that recognized that medicine was changing, that reform was coming, and that it was so much there was so much benefit to being part of a large system, not only from addressing healthcare reform, but being part of a large buying group and ability to get supplies and control costs, and it has really helped us in a significant way. MedStar has grown since St. Mary's Hospital joined the system. We're now 10 hospitals strong. There are 6 in Washington area and 4 in Baltimore. So we provide, and you'll see here in just a second, a lion's share of the healthcare in the region. MedStar did 204,000 admissions in fiscal 15, and you really look at the number of outpatient visits, which is north of 4 million visits. So there's a lot of statistics here. Some of these, I think, are just keeps growing. This is the net operating revenue, which is $5 billion in 15. It continues to grow. So it's a very, very large organization, and with that type of scope and that type of depth, you really have some advantages in the marketplace. So here at MedStar at St. Mary's, obviously we're well familiar with the main campus. We have our campus up in Charlotte Hall. where we will be transitioning our urgent care center to a MedStar branded prompt care late next month. The outpatient pavilion is attached to the hospital via this walkway. We have our laboratory center, and this is down in Great Mills. The hospice is a huge asset to this community and to this hospital. And the Education and Simulation Center is just down the road where the EMTs are. And this is an area where we do training and actual simulations. So we just did a MOST simulation, which is where we have a mock delivery of a baby, and we run scenarios with different types of complications and serious issues. And only by continuously training can you really get to be good at something. And this is something this community certainly knows about. I was at the Great Oaks ribbon cutting, and there were more jets flying overhead, and that's what they're doing, is practicing out there. We have a full range of services. I'm not going to read through every one of them. I think that it's easier to talk about now about what we don't do than what we do. I think the only thing that we don't do here, well, there's a couple things. So we don't do transplant operations, and we don't do interventional cardiology or open heart surgery. And you know, with the association with MedStar, and now with the partnership with MedStar Southern Maryland Hospital and the MedStar Washington Hospital Center, we really have a very, very strong cardiac program. We can offer some imaging of the heart and blood vessels through the use of cardiac CT, and our cardiologists now are at both places. So there's a lot of synergy in how we've set this up. I constantly speak about the fact that in St. Mary's County, we're really blessed. We're the only hospital in the county, and it's unlikely that there's going to be another hospital. Plus, now with the acquisition of the Shaw Medical Practice into the MedStar system, we have about 95% of the healthcare assets in the county. And so we need to execute, because we won't have that crutch to fall back on and say it's the competition that's getting us. So every day we get up and say, this is the best, we're going to be the best that we can. So we talked about issues with access and issues with the underserved, and so we have a very strong community outreach program. And we also obviously measure our contributions to the community, and we have to do that for the federal government. So in FY15, we did just under $10 million in community benefit and about $2 million in charity care. We have multiple grant-funded programs. The biggest is down near Great Mills, where we're putting up a health enterprise zone grant project the state has given seed money to. We're the primary leaseholder in a brand new building that's being put down in that region, and MedStar has committed $2.5 million to this project, as well as being the major the underwriter of the lease. So there's a large commitment from the system to improve access and help care down in this region. We'll have primary care, we have behavioral health, which has been a huge need in this community, and so we're very, very excited to see that project now with steel and concrete moving, and so we expect that will open up early in calendar year 17. We also have outreach programs. So I talked about the enterprise zone. We also have the Get Connected to Health vans. We have two of them. One of them is a much older vehicle that we just had retrofitted, and it provides dental care to patients in our community. And then the brand new larger van is a mobile healthcare clinic, and it's a really interesting piece of equipment. It looks just like a doctor's office, and that moves to different centers. Now that we have the Health Enterprise Zone building going up, we're rethinking the strategy on how to use these vans, but they've been a great asset over the last several years. I think I went back. So just a little bit about MedStar St. Mary's. About a little over 1,200 associates. 94% now. That's a new update. It was 85, but now it's 94% are county residents. Longevity at the hospital. 31% are here more than 10 years. We have about 890 FTEs and 89% retention rate, and we're a large contributor to employment and benefit in the county, providing about $74 million in salaries and benefits. The medical staff is comprised of about 400 doctors. That keeps growing as we add telemedicine specialists, and I'll talk about that in a second. There's a broad range of specialists, and they've grown, and we're going to talk about that in just a second. 96% are board certified. Most of them practice only in St. Mary's County. The average age is 47, and that's come down. The previous slide that I used to use for this, the average age was 51. So we have been able to get an influx of new blood, and that's terrific. And we have several new doctors in the pipeline that are going to be coming on board in the next couple of months. Physician practices are changing across the country, and it's no different here. So what you're seeing is a shift out of private practice and into employed relationships. And down here at MedStar St. Mary's, there's no difference. We still have some employed groups, both in the emergency department and anesthesia, for example, but more and more our physicians are part of the MedStar system. So this is the top item on our annual operating plan, and it's critical to not only deliver the highest quality of care, because that's what our mission is, but it's now become a must for financial survival. And I just want to remind everyone that the Institute of Medicine report on safety came out around the year 2000. And in the early 2000s is when this whole concept of pay for performance came into being. And if you look back, you think, well, the government was really quite generous in terms of the ramp up. So the slope of ramp up of pay for performance was very, very, very shallow. So we started looking at outcomes and things like infection and sepsis and mortality and how patients perceive their experience in the hospital back in those days. And we used to look at it and measure it, but it really had no impact on operations per se. The only impact it had was perhaps on the marketing aspects, and so people might choose it. But now, finally, the real carrot and stick approach of pay for performance is here. So we'll talk about this in just a second, but just to give you an idea, about 9% of all hospital revenue in Maryland is at risk based on the quality and safety metrics. And there's a triad that I like to talk about, the three-legged stool of quality-based reimbursement, and they are readmissions. So when a patient leaves the hospital, we want to have done as good a job as we can, and we expect them to stay out of the hospital for at least 30 days. And so we track that, and the state tracks that, and the federal government tracks that. And if your readmission rate is too high, there's a penalty involved. We track hospital-acquired conditions. So if you come into the hospital and you have what's called a central line, which is a catheter that goes into a large vein in your body for a variety of reasons, and you get an infection in the central line, or you get a urinary tract infection, or you fall and you break your hip in the hospital, these are all conditions that occur inside the hospital. This is a huge aspect of what pay for performance is. And when you look at the statistics over years of trying to improve the situation, you'll see the central line infections go from 10% down to under 1%. So it's really a discipline that needs to be there and is now, it's now incentivized to be there. So this is something that we work on every single day. These are some recognitions that we've achieved over the years that document our progress in being one of the top hospitals in the state. And we'll see here in just a second. So I talked about quality-based reimbursement. This score in Maryland is unique, but it's a zero-sum game. So the hospitals in the top half get some extra money. The hospitals in the bottom half lose some money. So there's a redistribution of funds based on this. This has been going on since 2011. The blue bar is St. Mary's Hospital, and you can see that in 2011 we were first in the state, second in the state in 2012, first in the state in 2013, first in the state in 2014, and fifth in the state in 2015. And so the fifth in the state, you know, always sticks in mine, and I think Christine's craw. But the reason is not that we're getting worse, it's that everyone has decided that they have to get better. So the bar keeps getting raised. And so we just have to keep ourselves in that fight. But I mean, really terrific performance over the course of the last 5 years. Also, I will tell you that the leadership from Chris and from the board has been amazing in terms of making decisions that were before their time, and has really led us to a place that we're way ahead of most of the other hospitals in the state, including in the system. So back in 2008, when electronic health records were not on anyone's major worksheet, this hospital made a decision that they were going to move in that direction. And so now we are a fully integrated electronic health record provider, and have been for 8 years. That compares to many hospitals in the state and many hospitals in MedStar that still don't have this capability. They're just getting to this area, and we've had to actually step back a couple of times to allow them to catch up with us in order to be within the system. So this is a result of great leadership, and what this has done, it has allowed us to take advantage of all of the federal dollars that were put toward upgrading electronic health record systems. And so we're one of the few hospitals that has been able to actually take advantage of all of that, all of those funds. And that's called meaningful use. We use an online variance reporting system, and we're unique in that our online variance reporting system requires that you put your name down. So if you see a problem and you want to report it, you got to attach your name to that. We think that adds accountability to the system. And the critics of having a non-anonymous kind of program say, well, that will prevent people from reporting things because they'll be worried that there'll be reprisals. Our slope in terms of our reporting is really very, very high. So we keep seeing increases of reporting every single year. And the most important part of this is that we're responsive to these variances. We look at them every single week, every single one of them, and get back to people about what they've reported. So one of the so we talked about some of the issues in medicine about whether we were going to be sort of sloppy like we were in, before the early 2000s, or whether we were going to morph into a becoming high reliability organizations. I like to give the example is that I remember flying in the 70s and even earlier, when inside airports there were a lot of life insurance counters that you would walk up and you'd purchase a life insurance because you didn't know. I mean, there's a chance that you could actually go down with the plane back in those days, and those are gone. I mean, you don't see them. I mean, there may be one tucked in a corner, but in reality, the reliability of flying has really improved so much that business went away. Well, we're not there in medicine yet, and that's what we're striving to do every single day. And I'm not going to go through the entire program. Here you can see some of what we've been doing in patient experience. It's a complex slide again. MedStar St. Mary's is in blue. We like to look at our competitors across the region, including Calvert and Charles Regional, and also the MedStar average. And so you can see that we continue to be one of the top performers in patient experience as well. So we talked about hiring all these new physicians and becoming the market leader. And so these are some of the faces of the new physicians and new services that we have. So we have new orthopedic surgeons that are part of the MedStar Georgetown Orthopedic Institute. We have a breast surgeon who's here and is fully trained and helping us become a certified breast center. We've got a strong women's health department with a gynecologist and nurse practitioner. Colorectal surgeon, Dr. Flatel is a wonderful and talented vascular surgeon, has added so much to the service line here at St. Mary's. And Dr. Gill is our new psychiatrist. He loved the area so much that he moved down here permanently, so we're thrilled to have him. And we intend to continue to build the behavioral health section, which, if you read in the news, is such a underserved area all over the country. We've got consultants from Georgetown. These are our pediatric consultants. We have new endocrinologists. And we have a whole slew of eye surgeons. And this is really a superb practice in eye surgery. All of these individuals are top performers. And our urologist was part of MedStar, joins Dr. J in the county, and so we're thrilled to have that service line growing as well. So part of the other things that we're doing to help become our market leader, it's tough to recruit doctors, and the way, if you look at where doctors aggregate, it's usually around where they train. So if you go to Chicago, you'll see a bunch of graduates from the Chicago training programs populating the suburbs of those counties. We don't have a training program here, but we are building a brand new residence for physicians. So this will be in a small condo complex where we'll have fully furnished apartments, and we'll be able to host residents who come down here and do some training. And a small percentage of them will look at this area and say, this is the area for me, this is what I've been looking for, and it will really help us in our recruitment efforts. And also, it'll bring expertise down to the residents of St. Mary's County. We also, this is a picture of the Lexington Park Health Enterprise Zone building that I spoke about just a few minutes ago. So I just want to touch on this subject of healthcare reform in Maryland. Maryland is a unique state. We're the only one in the country that pays hospitals in the way it does. So how it works, just briefly, is that there's a health services cost commission in Baltimore that looks at each individual hospital, and it looks at the capital structure of the hospital, it looks at its employment structure, it looks at the patient population, and it comes up with a rate for that hospital. And so that's the rate for the hospital. And statutorily, every insurance company, including Medicare, has agreed to pay that rate. And that's different. So if you go to Virginia, or you go to any other state in the country, what happens is that Medicare pays its standard rate, which is usually below cost, sometimes as low as 85% of cost. And so what happens is that hospitals and systems go out and they negotiate with insurance companies, and usually the rates for the insurance companies are just above cost to make up for the difference in the Medicare rates. And so we're blessed in that we don't have to go out and negotiate with insurance companies because we have a statutory rate. What it has, and the reason the state did this more than 30 years ago was because it wanted equal access for every single individual. And it worked very, very well. And sometimes there are unintended consequences. So when you have a system like that, it tends to mean there's more services. And indeed, in Baltimore, there's about 1,000 extra beds. At some point, the federal government said, hey, wait a second, we're sending about $1.5 billion more to Maryland than we would if we were using the old system. And so that's got to end. And so very quickly the state got together, and we're in a demonstration project where we have a fixed revenue. So right now there's a fixed revenue that every hospital gets. So every time a patient comes in, there isn't an additional charge. So if you do 10% more volume, the revenue is the same. If you do 10% less volume, the revenue is the same. That's the broad strokes of it. I talked about the 9% that could be at risk for quality and safety, and now you can see if you're a growing hospital and you don't keep your quality and safety up, you could really be behind the 8 ball, as they say, around your finances. So managing hospitals in Maryland has become a much more stringent kind of an operation. So here at MedStar St. Mary's, we're growing, okay, and when you have more patients, or 10% more over the last 2 or 3 years each year, what you find is your costs go up, but your revenues aren't going up. So this is a work in progress. This new demonstration project where we have fixed revenues and we're encouraging very, very high quality is being looked at all over the United States. And if it works, you'll see other states try to adopt this. It's unclear at this point whether the demonstration project is going to work. I will tell you that our goal of reducing Medicare spending by over $358 million in 5 years is well ahead of target. So there is some early evidence that we've been able to garner savings, but it's a work in progress. So I know that's complex, and I know we're running late, so I'll just go to questions and answers because I can see that we're well over time here today, and I apologize for running so long. Any questions for me today?